All right, moving on through the ECG course, still in level 1. We're in the finishing up the measurements unit. With this third lesson, we talked about PRI and QRS, and the numbers from those to remember were 120 and 200. The range of a normal PRI is between 120 and 200. If it's less than 120, it's short. That might be a junctional beat, or it might be an accessory pathway. If it's more than 200, it's a first-degree AV block. The impulse is pausing too long in the system there. A QRS, it's 120, so 3 little boxes. The causes of wide QRSs could be that it came out of the ventricles. It was abnormally conducted to the ventricles because of the bundle branch block. It could be a bypass track, again, that accessory pathway with the short circuit. It not only creates a short PRI, it creates a wide QRS. And then the last one is the QTC. So 120 and 200 are the two numbers to remember for those first two. Everybody, G-rated, all people, if you can spell paramedic, you need to know PRI and QRS. We like to go a level up, and the QTC comes in there. Now, what is the QT interval? Well, basically it is the total time for ventricular depolarization and repolarization, which I think just kind of makes sense, that you would want to know if the ventricles are having trouble, if they're taking too long to depolarize and then reset. That would be of interest. So in this case, the QT interval starts at the start of the QRS and it goes through to the end of the T wave. The end of the T wave, a wave and a segment, so the ST segment's in there, and in this case we have the QRS complex, which is 3 waves, and the T wave. So a couple waves with a segment in between, the QT interval. Now here's a good slide that you can read more carefully, and as you know, the PDF printout, more or less, of these slides is included with your Moodle lesson, and so you may want to read and review these things, maybe print them out, whatever you want to do. Maybe you want to watch this, this video screencast again. Really good information here about the QT interval. It's the lengthened time for the patient's ventricles to depolarize and then reset. Now, later on in level 2, we'll talk about refractory periods and this sort of thing, and this scary rhythm, torsade de pointe, will come up later on. But you know, here QT interval is the time for ventricular depolarization and repolarization. If that is prolonged, we want to know. So what's this C thing, the QTC? Well, I really wish it wasn't a C. I wish it was like A for adjusted, because corrected kind of gives the wrong meaning sometimes. It's a little bit confusing maybe. The C stands for it's corrected. It's adjusted for rate. Depending on the patient's heart rate, the QT interval will get longer or shorter based on whether the patient's going really slow or really fast. So the QTC is kind of standardized or normalized. It's what the QT interval would be if the patient's heart rate was 60 or a normal rate. So we're going to do QTC, and we're going to think of QTC as the indication for depolarization and repolarization, and we want to know if there's a problem there. And there's that really scary rhythm, torsade de pointe, or torsades, or TDP, and obviously I don't speak French, so I didn't say that right, and no one can spell it, so don't worry about that. But it is a particularly scary, deadly rhythm. It's polymorphic VTAC. It's VTAC coming from with a number of shapes, and it's kind of a strange little rhythm, and we'll talk about it more in a future lesson. I just need you to know right now that a prolonged QTC puts your patient at risk for torsade, and torsade is scary and potentially deadly. What causes a long QT? It can be meds, it can be drugs, and in our terminology, medication is something that is prescribed for you, and drugs are something you buy on the street to get high. So drugs, meds, electrolytes, it could be that the magnesium is low, the potassium is off, the sodium is off, the calcium is off. It could be one of those electrolytes that's so necessary for proper cell depolarization and repolarization. And strangely enough, it can also be from massive brain bleeds, central nervous system disaster sorts of things. The big risk, of course, is torsade. More cautions. sometimes we can give a patient a medication on purpose, therapeutically, and the side effect of that medication, meaning something that happens that we didn't want, but we're not shocked that it happened because it happens all the time, is that we prolong that QTC. And amiodarone is a common medicine that we give for ventricular rhythm problems, and amio can definitely prolong the QTC, which then puts your patient at risk for weird, scary rhythm problems like Torsades, and so we want to know that amio prolongs the QTC. So, what is a long QTC? Well, it's different for guys than it is for girls. I don't know why, it just is. 450 is kind of the average there. So I would say the QTC is prolonged if it's more than 450, but we're definitely worried if it's more than 500. There's a fair amount of debate as to what is a normal QTC or what is considered prolonged. So we're going to go with 450 technically, but 500 makes me really worried. And then what if you don't have a 12 lead? Well, the rough rule of thumb is that a normal QT should be less than half of the R to R. In other words, if it takes the ventricles more than half the time between beats to reset, then that is prolonged. That's the eyeball rule, the rule of thumb. I like to let the 12-lead machine measure the intervals because it has digital calipers, it's never wrong, and I don't miss long QTs if I'm disciplined enough to do M for measurements. I do R for rate and regularity, I do P for what are the P waves doing, is there P for every QRS, QRS for every P, and then I do M. I do it the same way every time so I don't miss stuff because my eyes will deceive me, but if I will read those numbers, my brain will get it right. Long QTC causes could be low on calcium, could be low on mag, could be low on potassium, could be too much of a TCA, could be too much of amiodarone or one of its cousins. It could be a medication thing or an electrolyte thing. Can you have a short one? Yes, you can. Short QT is usually a congenital thing. Sometimes can happen in infants and even young people up into their 30s. Short QT syndrome can put you into AFib or VFib spontaneously, and you may not even know you've got it. I mean, if you're a young person or you're an infant, who's doing 12 leads on you? Who's catching any of these weird things? So the first indication there's a problem with the QT, maybe the patient went into cardiac arrest and we got them back, did a 12 lead post-ROSC, return of spontaneous circulation, ROSC. We got a 12 lead and we see a short QT and they have short QT syndrome. So less than 300, more than 500, big hairy deal, and that kind of wraps up our measurements thing. Remember, PRI is between 120 and 200. QRS should be less than 120. QTC should be between 300 and say 500 to make things nice and easy. Technically, maybe more than 450. And so those are the numbers to remember, and it tells you that there's a problem in the conduction system. The reason we're doing measurements early on in RPM, early on in our analysis, we're looking at rate, we're looking at what are the atria doing, and then we're looking at what's going on in the conduction system. And the measurements allow us to assess for problems in the conduction system. So that's the measurements unit.